Hi everyone, I'm Jenny Moore. I'd like to start by thanking CoStar for inviting me to be a part of the second annual Implementation Science Conference. And I'd also like to thank each of you for taking your time to meet with us virtually over the 2 days of this conference. I'm going to start by providing some disclosures. I'm the founder for the Institute for Knowledge Translation and an advisor for the Southeastern Norway Regional Center for Knowledge Translation. And importantly, the project that I'm going to describe in this presentation was funded by NIDLR. I've been asked to take the information presented earlier today by Dr. Proctor and Dr. McDonough and provide a practical example of how it can be used in clinical practice. So I'm going to apply this content to an inpatient rehabilitation project called the Focused Intensive Repetitive Step Training Project. Now, this project had two primary aims. The first aim was to implement gait-related outcome measures in subacute stroke rehabilitation, and the second aim was to implement a high-intensity gait training program. And we were doing this to answer the questions of, can a research-based intervention be implemented into inpatient stroke rehabilitation? So is it a feasible intervention for inpatient stroke rehabilitation? And we also wanted to know if we were able to implement it with fidelity, whether the intervention would result in better outcomes than with usual care. Now, we've been working on this project for the last 5 years, so there's a lot of information that I could share, but I only have about 30 minutes for this presentation, so I'm going to give you a high-level overview and some of the lessons that we've learned from this project. I'm also going to reinforce the implementation science principles that Dr. Proctor talked about earlier today, including measuring the quality gap, selecting interventions to reduce the gap, assessing context and engaging stakeholders, planning for change, selecting implementation strategies, and evaluating success. But in order to fit it into the time frame I have, I'm going to rearrange these principles slightly so that I can describe the project while applying the principles as well. I'm going to start with assessing context and engaging stakeholders. This project was implemented at Mary Free-Bed Rehabilitation Hospital, which is an inpatient rehabilitation facility in Grand Rapids, Michigan. They have 103 acute rehabilitation beds, 48 skilled nursing beds, and in 2015, they had 342 stroke admissions. Now, their volume of stroke admissions went up during the time of this project, and in 2019, they were at 500 stroke admissions. Their staffing included 4.5 physical therapists on the stroke unit and 1.0 physical therapist assistants on the stroke unit. Now, an important thing to note about the context at Mary Free-Bed Rehabilitation Hospital is that they had a vision to become a learning health system. So basically what that means is that they wanted to implement measurements and use these measurements to improve the quality of care that they provide. And so this project really aligned nicely with the vision of the Institute. Now, at the time that we approached them about the project, they had not implemented the core set of measures for their learning health system, and they weren't exactly sure how to go about doing that. So in terms of alignment with organizational vision and what the leadership wanted to happen within the organization, this project was a really great fit. Now, we also worked really hard to engage the stakeholders in this project. We had our research and our clinical team, which included funded positions for a few people at Mary Free-Bed to really drive the project. One of those individuals was a clinician who was also working on the stroke unit and had a 25% position on the research project as well. In addition to those individuals who had funded positions on the project, we also worked very, very closely with the core stroke unit team because they were the ones directly involved with this project. So in order to ensure that we would have time to work with the physical therapist, we allocated funds from the grant to have staff meetings, to do the education and training, and to work with them to help them implement both the gait assessments and high-intensity gait training. Now, beyond that core group, this project also impacted all members of the stroke unit team, the OTs, the speech therapists, the nurses, the physicians, the rehab aides, the nursing assistants. All of them were impacted in some way by this project. So we did work very closely with each of those groups at various points in the project to help implement this successfully. Patients and caregivers are also important stakeholders to include and get feedback from about the project, and administrators stakeholders. We engaged with them often because we really needed them to help to promote this project, make it a visible goal of the organization. And also the technology or electronic medical records department. This department is key to any implementation project. It's really important to be able to work with the IT guy to be able to successfully alter medical records to get key data points, data elements collected and extracted easily. Now, an important thing to note about how we worked with the stakeholders in this project, we really took an integrated knowledge translation approach. Now, in this case, we interacted regularly with the stakeholders involved in this project. And as one example, we worked closely with the PTs on the stroke unit to select and to co-develop the implementation strategies we used for both parts of this project. After we conducted our barrier assessment for both of the projects, we had pages and pages of barriers, so we needed to work directly with the clinicians to prioritize them. We needed to know which barriers absolutely had to be removed to be able to successfully implement these specific practices. And then when we prioritized those barriers, we had to figure out which implementation strategies would be best. Even with the mapping tools that we have, there are many different implementation strategies that are suggested for each barrier, and so we had to work with them to figure out which one's most acceptable in their context. In addition to that, we went a little bit further to try to figure out the best way to implement those strategies within their context. Okay, so now I've talked a little bit about the Mary Free Bed context and how we've engaged stakeholders throughout this project. I'm going to talk a little bit about how we planned for change. In this project, we use the Knowledge to Action framework to guide our implementation process. The Knowledge to Action framework includes two components. The first component is the knowledge creation funnel, which is here in the middle. And then the second component is the action cycle, which is the implementation cycle on the outside of the figure. Now, the inside of the circle includes primary research, synthesized research, and development of knowledge tools and products like clinical practice guidelines. And it's all about tailoring the knowledge and getting it ready for implementation. The outside of the figure includes 7 phases to guide implementation. Now, in the first phase, it's important to determine the no-do gap, and this is very similar to assessing the quality gap as well. The second phase is adapting knowledge to the local context, and then assessing barriers and facilitators of knowledge use, selecting, tailoring, and implementing the implementation strategies or knowledge translation interventions, monitoring knowledge use, evaluating outcomes, and sustaining knowledge use. Now, an important thing to note about the action cycle is that there are bi-directional arrows between each of these phases, meaning that you can go forward or backward through the action cycle, and you may actually even do more than one phase at one time. Now, we use the Knowledge Action Framework to guide our implementation processes, but we also use some additional frameworks in a few of these phases as well. When we were implementing the gate assessments, we used the Theoretical Domains Framework to help to assess and categorize barriers and select knowledge translation interventions. And we use the NHS Sustainability Model to support sustainability activities in the project. During the GATE intervention implementation project, we use the Consolidated Framework for Implementation Research, or the CFIR, to guide assessment of barriers and selection of knowledge translation interventions. Okay, so now that we've talked a bit about planning for change, I'm going to go ahead and start talking about measuring the quality gap. And in this case, we actually had to do an implementation project to be able to do that, because at the time, Mary Free Bed did not have a core set of measures in place, so we needed to implement those measures to be able to measure the quality gap. In addition to that, we wanted to look at the characteristics of physical therapy. So I'm going to start by talking about what we tried to do to look at the characteristics of PT. So we developed this really nice documentation tool, and we asked the clinicians to basically double document what they were doing. We asked them to take this sheet with them to their treatment sessions and document what they were doing with the patients, and then give it to us so that we could quickly understand the characteristics of physical therapy. And after a couple of weeks of using that, we got a resounding no. That was just a lot of work. Clinicians don't have the extra time to double document. And so we worked with the electronic medical records department, and over time, finally figured out a way to extract these data from the medical record. But there was a delay in trying to get them out and then also analyze them, because the sheer number of sessions that we had to look at and figure out how to analyze was very large. In addition to that, we captured stepping activity using accelerometers on the patient's legs, and we were capturing heart rate monitoring activity using heart rate monitors that had sensors that could be clipped to the ear or the forehead. So in order to capture these data, the clinicians had to enter the information into the electronic medical record, and they had to put it in a specific place, and then we had to figure out a way to extract it. So again, we either had to do a manual chart audit or work with the electronic medical records department and make that happen. And over time, we were finally able to make an automatic chart audit happen for those specific fields. Now, in order to capture the outcomes of usual care, we had to do an assessment implementation project. So we needed to find measures that would be sensitive to change for gait-related interventions. And in order to do that, we looked to the research on gait interventions to see what actually changes as a result of these interventions, and that includes gait speed, walking distance, and balance. And we also went to published information that included recommendations for measurements. Now, at the time of the project, the American Physical Therapy Stroke Edge recommendations were already out. And then as we were implementing the assessments, the Stroke Rehabilitation Clinical Practice Guideline came out. And a little bit later in the project, the APTA endorsed Clinical Practice Guideline on a core set of outcome measures came out in 2018. And so the measures that we selected were recommended in all of these documents. They included the Berg Balance Scale, the 10-meter walk test, and the 6-minute walk test. And as noted in the core set clinical practice guidelines, these measures should be administered using the same protocol at admission and discharge, and when feasible, between these periods. So our recommendations were to administer these measures within 72 hours of admission, weekly, and within 72 hours of discharge. In addition to that, we did an annual standardization with a goal to get at least 90% reliability, and whenever items were not as reliable as they should be, we worked with the clinicians to improve this. But this was its own implementation project that we had to go through. So I could essentially take you through all of the principles of implementation with this particular project, but instead I'm in there for intensive repetitive mobility task training. It's recommended for all individuals with gait limitations after stroke. As we look through the guideline itself, there wasn't enough information about actually how to apply this to guide the implementation project in a way that the practice would look the same across clinicians and even across clinical sites. So we had to dive a bit deeper into the literature to find a good protocol to utilize for implementation of a gait training program. So I'll talk about that in just a minute, but I would like to note that this is a common problem when looking at guidelines, that there isn't sufficient detail in the guideline itself to figure out exactly how to implement an intervention in a way that's consistent with the literature. But with the APTA's guideline initiative, we're getting more and more guidelines that are specific to physical therapy, and this problem is getting a lot better. And I just want to take note that just this year in 2020, a guideline was published for improving locomotor function following chronic stroke and complete spinal cord injury and brain injury, with a recommendation to use moderate to high intensity walking training interventions to improve walking speed and distance, which is a very strong recommendation. But it should be noted this is in chronic stroke and not subacute stroke, and it's my understanding that there's a group working on a subacute clinical practice guideline right now. But going back to our project, the intervention that we selected after reviewing literature of patients that are similar to the patients that we're seeing at Mary Free Bed, we selected a high-intensity gait training intervention that was studied in several of George Hornby's research studies. So as a first part to selecting the intervention, we had to go into the research to try to understand how the intervention was delivered. So we synthesized this information to figure out the frequency, the intensity, and the time, and the type that the research is being done. We also found a protocol that was published in Halloran et al. 2014 that we were able to very concretely use and adapt for clinical practice. So we looked at how the research was done, and then we went through an adaptation process where we sat down with the clinicians to talk about what the researchers did in the research projects and what we thought we could do clinically. In the research, all of the sessions were high-intensity gait training sessions. They were able to achieve 2,500 to 3,000 steps per session, and of course this amount depended on the level of impairments generally, but they were able to achieve a lot of steps during a physical therapy session. So from a clinical perspective, we knew that we couldn't do 100% of the sessions as high-intensity gait training sessions, so we decided to go to 4 days a week, and we wanted to reserve 1 day a week for outcome measurement, data collection, and family training. In the research, they were able to achieve very high cardiovascular intensities, over 70 to 75% of heart rate max, and more than 13 to 14% of Borg's RPE. And they were able to spend more than 50% of the treatment time in the heart rate zone and more than 90% in the RPE zone. And so in the clinic, we thought that we might be able to do the same thing, but we needed to make sure that we adjusted the target heart rates for medications such as beta blockers as needed. But we decided to target greater than 14 RPE and greater than 75% of heart rate max. Now in the research protocol, they did variable stepping training on treadmills, over ground, and stairs. And they also practiced forwards, backwards, over obstacles in different environments. Now, from a clinical perspective, it would be very hard to do all of those things in one session. We would lose a lot of efficiency trying to go from one environment to another. And so the clinicians tried to vary the environments in which the treatments were being done, but they would do that to meet the patient's needs and maximize stepping training as well. In this project, we also decided how we would define intervention fidelity. And the first metric we decided to look at was changes in steps per day between usual care and high-intensity stepping training. Now, this was the easiest metric to use because we had the step activity monitors on the patient, and we wouldn't need to get any information from the electronic medical record to be able to look at this metric. We also thought it would be a good metric because previous research that we had done in an implementation project indicated that most patients did not walk much outside of physical therapy, which makes sense because they're in inpatient physical therapy. And so here you can see on the graph these little bursts of stepping activity. This is when the physical therapy sessions occurred, and then throughout the rest of the day, very little stepping activity was done in this particular project, both for the lower functioning patients, which is in the red, and for the higher functioning patients, which is shown here in the blue. So we really thought that we'd be able to capture changes in practice by looking at steps per day. In addition to that, we knew intensity is an active ingredient in this particular intervention, so we wanted to target more than 50% of the treatment time in the heart rate zone. And in order to get that, it required consistent documentation because the heart rate monitors that we were using did not automatically record these data. Okay, next I'm going to briefly talk about how we selected implementation strategies to implement the high-intensity gait training intervention into practice. We started with a barrier assessment, and then we used CFIR to categorize the barriers and select implementation strategies. Now, this is just a short list of the many implementation strategies that we used for this project. We don't have time to go into the details of these, but just know that there were many implementation strategies used. Now, one of the reasons why we used so many implementation strategies was that we identified many barriers. We had pages and pages of barriers that were identified by the clinicians, and we did a lot of work to try to prioritize the barriers, but they often shuffled. There were some things that were really big barriers at one time, but a few months later, they were no longer big barriers because there were some operational changes or some other thing that happened within the clinical context that made them no longer a barrier. So they were a little bit of a moving target. So we were often reassessing and trying to figure out how how to target the highest priority barriers, but that was a challenge. And so what we found was that we were frequently going back and forth through the top of the knowledge action cycle. We were assessing barriers, we were selecting implementation strategies and implementing them, and we were monitoring knowledge use to see if the clinicians were implementing with fidelity. And if not, then we went back to reassessing barriers and facilitators and going through the top part of the cycle again. Now, this was actually a key part of our implementation project because we did have several iterations at the top of this cycle, and this helped us improve our implementation strategy as we went through the project. Now I'm going to briefly talk about how we evaluated the success of the project. Ideally, we wanted to evaluate success at a clinician level, trying to understand whether the clinicians were adopting the new practice at a patient level. So if we were able to implement it with fidelity, we wanted to see if it made a good impact on patient outcomes. And we also wanted to look at it at an organizational level. And I'm going to start by talking a little bit about our adherence outcomes. And just remember, as I said, we had multiple iterations at the top of the action cycle. So we ended up with usual care plus 3 implementation phases, which we have labeled as phase 2A, 2B, and 2C. Here's the data from our usual care. We were able to collect data on 153 patients over 14 months, and what we found was that they were stepping just under 2,500 steps per day, but only 983 of those steps were happening during PT sessions. So there was a lot of walking happening outside of physical therapy, which didn't happen in previous implementation projects that we did. And so there was a little bit of a mismatch between our fidelity metric of steps per day and what we were seeing in terms of walking inside and outside of physical therapy. All right, so our first implementation phase it was 15 months long. We're calling this phase 2A. At the end of this 15-month period, what we saw was actually a drop in steps per day. It went from 2494 to 2409. This was not a significant difference, but we did see that it had gotten lower. And we also saw that the steps per PT hour increased a little bit. Now, I should also give you the context that the patient characteristics did not change. The impairment level of the patients did not change during this time period. But what we actually saw was a slight decrease in stepping outside of physical therapy and a slight increase of stepping during physical therapy. But in the end, it made it look like the patients were stepping less on a daily basis. After we got that data, we went and described it to the clinicians. We had a meeting with them. We reported our preliminary results. We reassessed barriers. We initiated new implementation strategies. Then, after collecting data on 48 patients, we reassessed fidelity. And what we found was that steps per day did increase to 27, just over 2,700, and steps per PT hour continued to increase to about 1,276. After this period, we went back, we met with the clinicians again, and we shared these data with them, and then we gave them a specific stepping goal. We asked them to try to increase their stepping by 600 steps per day for each patient. We reassessed barriers, we developed new strategies, and then we tried again, and we collected data on 63 patients, and we ended up with another increase in steps per day to 2847, and then the steps per PT hour went up to 1542. So if you compare usual care to phase 2C, which was the last phase of the implementation part of the project, you can see that steps per day increased from just under 2,500 to about 2,850, and the steps per PT hour went from 983 to about 1542. And so what we saw was that steps per PT session was significantly different from usual care to the implementation phase, and they did significantly increase in every single phase. Now, our metric was steps per day, though, and when we looked at steps per day, there was not a significant difference between usual care and the implementation phase. And when we just look at the steps per PT session in isolation, the numbers that we got here were also much less than the numbers of steps per PT session that we were seeing in the research. So at this point, from a stepping perspective, we don't think that we have been able to implement it with high fidelity. So then we looked at our adherence with heart rate and RPE monitoring, and we didn't monitor heart rate during the usual care phase. The clinicians didn't continuously monitor. It wasn't part of their routine practice, so you could say that it was 0% during that phase. But during the implementation phases, we actually saw our strategies increase the documentation of heart rate from 15% to 64% of sessions with some sort of heart rate or RPE documentation during the implementation phase. But when we actually looked at whether target intensity was achieved, it was reached for at least a minute in 33% of the PT sessions that included heart rate documentation, but we did not get to our fidelity goal of at least 50% of the PT sessions. So what's next? Well, since we haven't implemented this intervention with high fidelity yet, we would need to continue this project and not evaluate the impact of this project on patient outcomes yet. The next step would be to continue to assess barriers, continue with implementing strategies, and continuing to monitor until it's implemented with fidelity, and then patient outcomes can be assessed. So in summary, in this inpatient rehabilitation project, we were able to implement outcome measures successfully with high levels of fidelity, but within the same context, the same clinicians, the same leadership team. It has been much more difficult to implement high-intensity gait training with high levels of fidelity. Heart rate monitoring documentation has increased, and the implementation strategies have resulted in significantly improved steps per session, although not steps per day. So more work needs to be done to be able to implement this with fidelity. So I'd like to wrap up with some lessons learned. First of all, implementation takes time. It's important to be patient. It's important to continuously assess what's going on within the context, because the context itself changes with time as well. It's also important to think of time in terms of what you need to prepare for your grant. Budget for time for collaboration. Budget for the clinicians to be able to meet with you, for the management team to set time aside to be able to meet with the research team and talk about the implementation efforts. It's also important for clinicians to be able to have time to accept and adjust to the new practice. We kind of naively believed that we'd be able to very quickly implement this and the clinicians would accept it and make it routine practice almost immediately. We didn't give enough time for the clinicians to accept that this should be the new normal and figure out how to make it their new normal. And also think about the time required for medical record modification. This was an ongoing challenge in this project, and it's an ongoing challenge at every inpatient rehabilitation project that I do. So if you can budget time for that IT guy to be able to work on medical record modifications, that could go a long way to make your project successful. And in our case, we wonder whether we should have had more comprehensive fidelity metrics. We think we may have lost some efficiency in implementation because we were looking at fidelity rather narrowly. If we were looking at the characteristics of physical therapy, we might have been able to capture a little bit more of what was going on during the physical therapy sessions to be more efficient with the implementation. I'd also recommend to start planning for collection of fidelity metrics right away and start planning with that IT guy so that you can get the information that you need into the medical record and get it extracted easily when you need it. And lastly, I would just like to repeat what Dr. Proctor said earlier. It's all about context. We had the interesting opportunity to run 3 parallel projects at the same time. We implemented this project at Mary Free Bed. We also implemented the same project using the same methods at a hospital in Indiana and at a hospital in Norway. Now, the hospital in Indiana and Mary Free Bed are both still working on improving fidelity, but the hospital in Norway, which we're calling the Project First Oslo, we were able to very successfully implement this into clinical practice, and we recently published a paper on the impact of high-intensity gait training on patient outcomes in their context. So again, it's all about context. We had the same project that we were running across these sites, but they all in the end looked very different because the contexts were all very different. Okay, so thanks again for your time and attention. I really appreciate the opportunity to speak with you guys today, and I look forward to hearing the questions that you have about the presentation. Thanks a lot. that there was a glitch and it skipped over a few key slides in the presentation. So I just wanted to take a quick moment and review these with you guys. I believe this is where it kind of fast forwarded through a couple of the slides. So I'm going to start off here where we were talking about the implementation of the gait assessments. And basically, this was for the first implementation project in which we were trying to assess the quality gap. And we recommended, or we used 3 highly recommended measures, the Berg Balance Scale, the 10-meter walk test, and the 6-minute walk test, and we administered them in a way that aligns with recommendations in the core set clinical practice guideline, which is that these measures should be administered using the same protocol at admission and discharge, and when feasible between these periods. So we recommended that the measures would be administered within 72 hours of admission and weekly and within 72 hours of discharge. And so in addition to that, we did an annual standardization and reliability test on that. In order to get this gait assessment battery in place, we used 18 implementation strategies, and we don't have time to go into the details of these, but I just wanted you guys to know, just like the gait intervention implementation, we used a combination of many strategies to get this into place with high fidelity. And here's a graph that shows the adherence to administration of the outcome measures. You can see that it took about 6 months to achieve greater than 85% adherence, so which is the goal right here. And basically what that means was that 85% of the expected data points were there. And so we basically used our iterative process of looking at barriers and developing new implementation strategies over this first 6 months. And then we just continued to monitor to see what would happen with adherence over time, and we added more implementation strategies as needed. So we actually just recently did a follow-up on this 48 months post, so about 4 years after we initiated the implementation. And these measures were in place still, and the adherence was greater than 95%. And so we were very, very excited about this particular project because we very successfully implemented the gait assessment battery relatively quickly, and it was a sustainable change in practice, and we collected a lot of great data on usual care. So we really believe this set us up very well for the next implementation project that we were doing, which was selecting the gait intervention and implementing that in practice. So I believe that's where the video picked back up. So it's just an important point with this particular context that we had one extremely successful and very quick implementation project in which we implemented the gait assessments, and then we immediately went into this gait intervention implementation, and it was a lot more challenging to get that into place with high levels of fidelity.